So I'll tell you right now, we don't know. But I will tell you, the government has some general responsibilities that have to be met. So really, on an individual basis as an employee of the government, I don't think my job's going to change a whole lot. One of the things is that we're kind of at elbows length, so there's kind of an advantage for our office too. Some days they forget we even exist, and we go, come on, how come we never got the email on that? And other days they forget we exist, and we go, until we're ready to be there at the table again. So in terms of how will that change from government, I don't know. There may be some ministry changes. Health generally stays fairly much the same. In terms of will a form change and will an application process change and stuff, if any of those things happen, they happen over a long period of time.
Why I'm asking is because health services for Indigenous, it's always contentious.
Yes.
So
I would agree.
That would be a really big, important part of your information.
And so I think there may be areas where you see that they make some major structural changes within the health system if there's a change in government, and you may see those along the way, and we may have to again catch up. They are always changing too. So and there is no possible way that anyone, let alone anybody even in our office, and it's our jobs to do that, know everything that's happening in the health system at all times. We just can't. So we're going to be running to catch up, for sure.
Well, I think an important piece kind of in reflection to that is that the Alberta Health Advocate is mandated in legislation.
Yes.
So the benefit of that is that a government just can't come in and change legislation. The health advocate is legislated, it's there, it's not going to change. This is the thing, when you're an advocate, and you're thinking about how you want to make systemic change, there's often two ways that people will think about it. They'll think about it as policy making change or legislative change. If you're looking at it as policy making change and you make a shift in policy, you know that policy will shift with the election cycles.
You do.
Legislation, if you want to make longer term systemic changes, is the way to go, because then it's in it is legislated. It's not something a government can just be like, okay, we don't want that today. It's in law.
So what would the for Native people that are under the Indian Affairs? Is it Indian Affairs?
Big pardon?
Yeah.
Federal level? Federal? Would it be the legislative changes that they make to our?
No, so the provincial election's not going to make any difference on that. This election coming up will make no difference on that because that's a federal issue, right? The relationship between the federal and provincial governments might be different, might have some impact. Yeah, the answer to all of this is we don't know. From an office perspective, though, Renee is absolutely right. There are some offices that have been created by what's usually called an MOU, and it's a memorandum of understanding. So we've created this office. It's basically a policy decision. We think there's a need for this office. We've created this office or program. It's done under an MOU. Those ones are way more at risk. We have legislative backing them. Yeah.
I think I understand what she's saying, because what you guys are fighting for is for all Albertans.
Yes.
Under the Alberta Health.
Yes.
But we fall under a separate category.
You do.
Through Indian Affairs.
Yes.
So she's wondering how your office and federal, like with the Indian Affairs, you guys are not connected at all.
We are not.
If we have complaints and we want to call Indian Affairs, they won't even give us the pen and paper. They
Yes.
will only speak to our doctors or any healthcare officials. So we can't even advocate for ourselves through Indian Affairs.
Yes.
And I think they changed their name. I don't know. Indigenous Services.
Yes. But everyone still calls them mine.
Yeah. So that's what she's bringing up, is how do we advocate for our people through Indigenous Affairs?
So there's a couple of things in there.
Well, I only have a little bit to say on that. Just, yeah, I'm not sure the name changed. INAC is what I used to call it, but I know it's changed since then. If it were like a medication issue, it's definitely outside of our office's ability to have much influence there. But if you're trying to access services at a hospital, Lethbridge, wherever, that still falls under Alberta Health Services. Yeah. And a concern or a complaint or whatever would and should be brought to our office for discussion, for sure.
Okay.
So
that's my number one.
Crossover. Sorry, did I?
No, that's really good.
I'm standing up because of my back now.
Okay, but that's really good. So that's my number one. So, and you may not know, right? You may not know. It's okay. Again, it's okay to call and say, I got this going on. Is this something to talk to you about or not? And is this something, the other piece to that is this is something that we want to do more of. So because we're still a fairly new office and we're still trying to build a whole bunch of those, you can trust us, we're not gonna be on the head, you know, with a lot of other organizations and all that sort of stuff. We're still working on lots of those. This provincial federal thing is very, very dicey, as you well know, on all kinds of issues, not just on health. But that's certainly someplace we want to go to. We know, sorry.
But I noticed, like, in some areas they notify the people, but here in this area with Indian Affairs, we're never really notified of the changes that they make. So where can we get that information?
Who do you, say that
Well,
again?
if there's
Give me an
changes to the
example.
health, like, let's say you need to go see a dentist, and you're covered for this
Right.
and that, but all of a sudden you go and they stopped covering this and.
Ah, so do you have a
Paper and
health
it's,
rep on
No,
reserve?
that's what I just
Don't.
said.
You
That's
have
what I
no
just said.
health rep on
We don't have
reserve.
an advocate for us to advocate with the federal government for Indian Affairs. Because like what she said, they made changes to our
Yes.
prescriptions.
Yes.
If we
No one
go
told you
in,
that.
if we go in and we want a medication, if we are working, they will run our private insurance first before they run Indian Affairs. But it never used to be like that, and
No,
they changed that
it
back in
didn't.
2015. But the First Nations people were not even aware of those changes.
The only thing that you have really is the Canadian Human Rights Act
Yeah.
in that respect. And so what makes me think about is, it connects to the non-retrogression piece that we talked
Yes,
about,
it does.
is that if there is such a fundamental violation, that the Canadian Human Rights Commission is the place to go. And we have officers up in Edmonton, the Canadian Human Rights Commission, and I would have to say, out of the federal versus provincial commissions, the federal is much more progressive and ready to take stuff on. So if there is something like this that comes up, especially when it's the retrogression of like prescriptions or whatever, I would call the Canadian Human Rights Commission. Because they will know how to navigate that. And because they're the only office at the federal level that has any sort of space for advocacy for First Nations people on reserve.
That would be the
Okay.
same for education too, but
Yeah.
nothing.
And they've
We are
been
never notified of the changes, like,
So-
you know, like the federal government, we fall under the Indian Act.
Right.
Which coincides with the federal government,
Yeah.
Right.
which they're just puppets
Right.
for the federal government.
Yeah.
We don't really have sovereignty for our people, to tell
Right.
you the truth.
Yeah.
And so all of our changes that come with healthcare,
Yes.
medical, education,
Yeah.
all of these areas, the people are never notified of the changes that occurred. And when we go to chief and council, they don't share that information with us. So that's why we're getting really frustrated, is
I
we
believe
need
it.
people to advocate for us.
Yes.
To be able to make that connection with Indian Affairs.
Yes.
Because they won't even talk to us. They'll only talk to chief and council or to the doctors or dentists, and that's it. There's no.
So interesting. Because I was telling you earlier, I worked on reserve for a couple of years, but it's quite a few years ago. See, and we had a health rep that was on staff, on band council staff at the time, and that was exactly her role, is to be able to explain to people what is covered, what isn't covered, how do you do that, all those kinds of things like that. That was exactly her role. So that's my not being up to date. Again, how do you keep up with health?
We do have, like, if they get bulletins when the government changes and stuff, they put bulletins out there, just not, it's not like, out in the news, like
Yeah.
front page news, if you get a
Right.
bulletin.
Okay.
You can call non-insured health benefits, and they're not always very helpful, but that's who you would go through for any issues with your healthcare stuff.
Okay.
So
So there's
non-insured
kind of
health
some, but
benefits.
not quite as much as there was.
Yes, so it's
Okay.
non-insured health benefits that you would contact. for
Okay.
So that would
any
be like
issues.
your advocate, that's the closest thing. you
That
have.
would be your.
That would be your closest thing.
So you're
Okay.
pretty much
But
left
that's
to
the
do
thing,
it
our
yourself.
Fair enough.
No, we need to
Thank
share
you.
that information.
Well, now you know.
So one of the things that I noticed was, like we're talking health insurance and the benefits that we get as First Nations people in Canada. And so, in a personal story, just quickly, but then when I reflect on it and I compare it to bigger issues, it seems like that's how, I don't know, society looks at things also.
Okay.
So I had gone in to see the doctor. I have coverage with INAT, and I have my own working in the business that I work for. I have that insurance also.
Yeah.
So I had gone in to see the doctor, and again, it's this issue. Indian Affairs, no, we're billing this person first, and then they'll pick up that. And I was like, no, well, it should be the other way around, because this is our right. As far as I know, this is our right to have our eyes and all that kind of, they have to make sure that we're able to have those checkups and all that kind of stuff. And so they did that, and then I went through the process, and then it came down to the glasses, to pick out the glasses.
Right.
And I found out that they have just a section for First Nations people to pick from. And then they have another section for people with other insurance and non-native people that can pick, and it was the quality of the glass.
Well,
So if you're a
where's your
First
eye
Nations
doctor?
person in Cardston,
Why does that not surprise me?
Yeah, I've never run into that, and I
if
have
you're
not
a First Nations person,
work
you
insurance.
get what you get. And I was like, and then how I picked that up was some lady said, well, only Indian Affairs covers this. And I said, what? Oh, you can only pick from this.
So if you use your private insurer, you can pick from the rest.
If
but
you
you don't,
use, then you can pick from there. And so when you look at it in a macro level, and you go, like, let's say into the hospital, and you have people with private rooms, and or however the standard time you can stay in the hospital after you have a baby, all those things, like the medical care that you get what you get. But how do we know that? Like you're saying.
First payer, and some is a second payer. The same way, so say my husband he has medical and dental through his business that he works for, and I have it through Provincial Government who I work for. And so sometimes one insurance pays first, the other insurance pays second, right? And that's part of the insurance piece to that, but that of course is linked to the INAC piece of that too. So are they a second payer? I don't know that, but that's really interesting, and the glass is bizarre.
And
No,
then,
it is policy. They changed it in 2015
Is that
because
right?
I went to orientation for KBE over the summer in June, and they switched from their old insurance to a new insurance company.
Wow.
And that's what he stated was,
It was about who's the first
anytime
payer.
you go and get prescription or go see the doctor, they're gonna charge your insured,
Other insurance first.
private insurance before they charge the Indian Affairs. And if these pharmacies don't do it that way, they'll be fined.
Sure, yeah.
And that changes since
and so the
15,
thing
right?
is that for those people that don't have a second insurance,
That's right.
they get what they
They
get.
get what they get. Absolutely.
That's
they do.
very
They don't
similar to
have that
age.
opportunity.
Yeah, very
Yeah.
similar to H.
And
Yeah,
that's
it's
why
just one
people
system
are
and not
getting
another.
generic medication,
Yeah.
and you're getting more reactions because of the genetic.
For sure. Gentlemen, you had something? Oh, you were just messing with it. Okay, I'm gonna come back to this, but thank you for the discussion along the way. This goes back a little bit to our philosophy that we were talking about. So when our staff are answering those phones and you're calling there, we're really trying to look at you in your environment. So where are you at right now? What is happening with you right now? You, right now, the environment that you're at. And whoops, there we go.
Going the wrong way?
We keep going the wrong way, but, okay, we're finished. That's it. So we're looking at that. We're looking at trying to create autonomy for you. We're looking at some client self-determination. We're looking at, so you'll find that people will ask those kinds of questions. What did you try before? Did you ever do this? Did you ever have that? Here's some options and some thoughts. So, and you'll see in the health charter, and this comes to the health charter issues as well. The health charter is really kind of aspirational. So if you're going to try and make that into exact rules of what should happen in the health system, good luck. We don't know how to do that. But it does say, kind of in a perfect world, this is how the health system should work. And it says the health system has a responsibility to me as an individual in Alberta to also have a responsibility to the system. So we're working on that side of that too, and we're saying, okay, so what do we need as people then to play that part? What do we need to know? What ammunition do we need to take to the table so that we know how to do that? So this is the way that we try to do our work. This is talking a little bit more about the Health Act. We talked a little bit about that. But the health charter, as I said, is really aspirational. I'll tell you a secret that's not a secret anymore because I keep telling people. Apparently the health charter was written on a napkin, a paper napkin, at a restaurant. That's where the first draft of the health charter came from, which I kind of like, because that sounds like real people. Like, have you ever done that? And you're like sitting there with somebody and you're talking with them and you think, write down your name, I need your email address because we're going to talk again, right? And you write it on that serviette and you stick it in your pocket. And then later you go, I'm going to throw that out, and you realize you have stuff on it. So I kind of like that because it's more like real people. I think it was actually a minister of health who was doing it, so that's probably not real people, but I guess, I guess just like the Queen, he goes to the bathroom.
I just did that, I was
Yeah.
looking through my thing, and I came across
See?
an incident with the city police that gave me contact info for the dispatcher, or the
Yeah.
manager of the dispatch, you know, of
Yeah.
Alberta. He said, so if you ever run into another issue, so I'm looking, because I was looking through my book, and I'm like, where did I put that number? And then it just on an odd piece of
See?
paper, I was like, oh, that's
See?
important info.
See, that's important. So I kind of like that. But you know, for the first time, and we are the only province that has a charter, a health charter. And for the first time, there was somebody coming out, I think, when this happened, to come out and say, you know, it may not be right today, but this is what it should look like. And we have a right to be able to be working towards what it should look like. So as much as we have not done any major reviews at this time, we believe that what we're doing with every one of those cases is putting them up against the health charter in our brains as staff and saying, well, yeah, somebody wasn't listened to, or somebody wasn't given access to this, or somebody wasn't, that's what that is. You know, I feel very strongly that by using that health charter to guide ourselves, it keeps us on that straight, narrow pathway. It's all about the individual. It's all about that client, that patient, and if we see what they really need, then you know what? The system will actually work the way it should. It's when we start getting so caught up in what the system should look like and we forget about people inside it that we get into trouble. And we hear it over and over again from people who call every day. So this is
charter on the web?
It is on the website, and
You have copies.
You have copies of it, and we have some
Okay.
more of them here too. If you
Okay.
need them, you can pass them on to people. You know, you can stick them to the napkins even if you want to. So this is kind of the kind of stuff that we do, and it keeps going to the minister. So Kathy met with the minister about a week or so ago, and had a good meeting. We make sure that she takes some of the really important stuff that we're hearing. Everything's really important, so we try to compartmentalize it and say, here's some issues that we've been hearing a lot about lately, those kinds of things. And really try to say to those powers that be who make big decisions that these are things we're seeing. It's not our office's job to identify how it's fixed. It's not our job. We probably have some ideas. Sometimes we get a little bit, you know, but we have some ideas. But we do know, we know for sure, the way to fix a lot of these things is to become more client-centered. More client-centered means it's driven by the patient, by the person, and it meets their needs. So we do know that. So the other thing that we tell people when they call too is that, well, in so many words, we tell them we don't have a big stick. We tell them that the best we can do is try. We can try to give you options. We can try to look into some things. We can try to look up for some things. But we cannot make some other body do something. So if I've had problems in the ER in Lethbridge, and I phone Ryan, and I say they didn't treat me right, first of all, he's going to probably send me to Alberta Health Patient Relations. But he also can't go down to the ER and go "Arr, arr, 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 arr," to all the people who didn't treat me right. Can't do that. We don't have a big stick. There are days we wish we did, that we'd have a big stick. But you know what? By and large, most people, you know how most people on this reserve are really good people. Most people are. Most people who are firefighters are really good firefighters. Most people who are social workers are really great social workers. Then you're always going to get some that are not. And so we try to remind ourselves, that's how we get through the day. We try to remind ourselves that all we hear are the bad things, and that there are some good things happening out there in the health system, and try to believe that there are, because there's lots of people like us who work in the health system who want to make it better all the time. And they're working hard to try and do that. There are. The problem is when we come across some of those people who are that proportion that don't. Just like the firefighter who doesn't, or the police officer who doesn't, or the social worker who doesn't, any of those things, right? And that's where we hope we're there. Big stick would be kind of fun some days, but we don't have it. And so we don't ever promise that we can make huge changes. What we can promise is that we will try, and we will do the best to help people help themselves. That's what we try to do.
Good.
There's the charter. You'll see as you read the health charter, and mostly I'm just going to tell you, there's those pieces. What about the health system? What's their responsibilities and rights? What about the individual? Their responsibilities and rights. Yeah. Oh, look, you're making, see, look at it, that's that fancy thing. I didn't do that. I don't know how to do that with the PowerPoint, but it pops up all the little words that come with it. But you'll see all of these elements within there. Funny enough, think back to what Renee presented. You see the similarities that are right there. Very much the similarities that are right there in terms of concept. So now what I'm going to do is I'm going to pass it to Ryan, and he's going to talk the specific piece that's on the mental health patient advocate. Then towards the end, I'm going to come back to some of those practical tool things that we're going to do. Okay? Right.
Get someone treated against their will, how you can control a person against their will, rules around discharge, rules around what's called a review panel, which is a check and balance, and then of course in Alberta's case, which is the only direct case in Canada, they threw in the mental health patient advocate where we work, so that's legislated. Have I lost a whole lot of people here? Okay, so when we talk about rights, it's actually very interesting coming to today because I don't know much about rights. I work very much frontline on the ground. So when we talk about human rights, I'm like, well, what are we talking about as a human right? Does that mean it's legislated? Does that mean it's enforceable? Because in the work that I do every day with the clients that call me, we talk about these seven, eight specific rights that the Mental Health Act mentions that we can actually enforce from our office's perspective, from the doctor's perspective, from Alberta Health Services and Alberta Health's perspective. We can enforce these things because they clearly say in the Mental Health Act that these things need to occur. Everything outside of that, we actually, well, we didn't come up with the term, probably the doctors or the system did. Everything else outside of that is called a privilege. So let's move forward here, because I didn't make this PowerPoint.
Want that one or no?
Let's move forward and then we're going to come back.
Okay, let's go back.
And move forward from this one
Okay.
too. Because I think I'll lose less people.
There we go.
And even more forward.
One more. Okay, one. Oh,
Keep
no.
going.
There we go. That's the one we want.
There's a reason why I talk about this. Because we might as well start at the beginning and then it makes more sense. So on reserve here, the police that are here, and or any peace officer, and or if you're off reserve, any peace officer, that you come into contact with that feels that you're suffering from some sort of mental disorder, could be anything under the sun. They have the authority under the Peace Officers Act to bring you to the hospital against your will. And that's kind of a key thing to know. So, okay, so if I'm unwell.
What if that violates your fundamental rights under the charter?
It absolutely
'Cause it
does.
does.
It absolutely
It does.
does.
That's how we got this.
Yeah, so these are the exceptions. So, and I talk to a lot of people that will tell me that, well, this is again, it's the Charter of Rights and Freedom. I say, absolutely it is, absolutely 100% it is. So each province, on top of having the charter, makes this legislation. So which supersedes, I don't know.
The human rights
But
does.
it should. So I will say, well, if you have a lawyer that cares enough and is good enough and et cetera, and takes this case to the Supreme Court of Canada, they might say he's been arbitrarily detained.
Yeah.
But in the meanwhile, this is what's actually going to happen to you. So as a frontline worker, I like to really talk about what's actually going to happen, so you can make the most healthy choices for you when you're going through the system. There's a question here.
Yeah, so actually, one of our co-founders, Melody Bastine, she's not here today, but she actually had a situation like this where one of her children suffered from mental illness, and she lives on the Beginning Third, and so it's RCMP, not tribal police, and she actually wanted her son to be admitted, but the police officer would follow that.
Okay, so I'm going to address that right now.
Okay, good.
So we have this whole, I'm colorblind, so tell me if my colors are wrong and it doesn't make sense. I think green.
Great, yes, good,
Green.
whoa, good.
If you notice. All this green talks about how to get someone in the hospital. So tribal police and RCMP at any time can just bring you to the hospital. They don't always do that for a number of reasons. They're not there to make a mental health assessment. They're there to say, something's strange with this individual. I need to bring them to the hospital for a doctor to check them out. They have no more medical experience officially than that statement. So they sign what's called a Form 10 based on that, okay? And that's under the peace officer's power and the Mental Health Act. So that's why people get picked up and brought to the hospital. It's not the only way people get brought to the hospital.
You said Form 10?
Yeah, Form 10. So what happens, and let me go through it all, and then if you still have a question, what happens is the police come into your house tonight because you called because your son was acting out and busted down the door and there's yelling, screaming, and throwing things. All of a sudden, the police show up to your house and he's playing video games. What are you talking about? I'm just fine. The police have no authority to pick him up out of the house and bring him to the hospital because they have to see an active incident for their consent. Okay? A couple other ways that a person gets brought to the hospital. You can go before, so say that has occurred and police have left again, they're not helping again, our community's suffering again. You can go to a provincial courthouse, I think the closest one here. I don't know if Carson has one, but Lethbridge. Oh, it does? They all have provincial? Okay, good. Go there and you can ask for what's called a mental health warrant. And you do it by filling out what's called a Form 7. Okay?
What was that again?
A Form 7.
Okay.
And that's essentially you taking an oath saying, this is the circumstances with my son or daughter or mother, this is my concern, this is why they need to be in the hospital. Things you're going to know off the top of your head, you don't need
Can
to
it be
bring.
a friend that does it for somebody?
Anyone under the sun.
Okay.
How about an ex?
X? You have no idea. How many X's? Yeah, happens all day long, I assure you. So what that does is that goes before a provincial courthouse judge. The judge is going to meet with you down here, it'll be very quick, probably the same day or the next day. In Edmonton and Calgary, you're looking at 3 or 4 days depending. The judge is going to meet with you in a room and you're going to tell them the story, what's happening with your loved one or your client, whatever. And the judge will decide, based on the information you provided, if they will send out the police, whichever the local police would be, to go and find that person and order them to be brought to the hospital. So the police will go and apprehend them, and the judge can issue that warrant for up to 7 days. And the police, if the police are concerned, so around here, for example, tribal police would likely know the person, and they will know if this person's a concern. So now they've got the judge's warrant. They can ask the judge to review that for an additional 7 days. So they got up to 14 days to find the individual and bring them to the hospital.
How much information would you have to have on that? Would you have to have a lot of proof of that though? Or?
Here's the thing with proof. If the judge believes you're lying, and not a lot of people lie in this circumstance, right?
Yeah.
I mean, they have other powers where they could probably have you apprehended for, I don't know what all the rules are around that, because that then gets into the criminal code.
Yeah.
This is all done under the Mental Health Act. So there's a presumption that you're telling the truth and that this is a loved one of yours or a client of yours. So you're not typically falsifying information. You're providing information about, does the person have weapons? Does the person have a history of mental health? Does the person have a history of addiction? Does the person have a history of violence, all these sorts of normal things that you would just think about, which is why you're concerned in the first place.
All right, sounds good.
Yeah.
How much, like, do you have to take it at such a high level though to bring something like that to court? Or like, you know, if a person does have like serious, like, you know, like what kind of level?
Let me back up 3 steps.
All right.
And we are gonna back up here on the PowerPoint too. For the majority of us, all the time, and when, as advocates we want, and as families we want people that have health concerns to go to their doctor and access the doctor on their own, or go with us, or get in the car and voluntarily seek treatment, receive treatment, get good treatment, and get discharged and be helped. That's the ideal world, right? And we know that that doesn't happen. This is only for, I've tried to get my son to the hospital. He won't go. He won't get in the car. He's dangerous to get in the car because he'll jump out while we drive, right? This is for when all that doesn't work anymore.
Okay.
So there are certainly people who are in hospital who have taken themselves there.
The
Or
majority.
family said, you know what, Renee, you're not doing well, let's go off to the hospital now and let's see if we can get something done.
Right.
But so there, and Ryan will go through that, what's an involuntary and a voluntary
Oh,
patient.
right.
So just because I'm in hospital doesn't mean they're forcibly detaining me there.
Yeah.
Okay.
This
Right?
is to force someone into the
It
hospital.
could likely be, but doesn't mean.
All right.
And when,
There's-
Yeah, just real quick, so when somebody that self-identifies goes and then gets discharged numerous times without getting the support from mental health,
Yeah.
I've seen that happen so many times.
All day long.
Can-
all day long.
What can you do as a friend that sees this guy suffering from addiction, needs the mental health help, isn't getting it?
So-
What can I do to help support that friend
It-
in
it's
getting the help?
Many things, it's a bigger conversation. It's why we're mostly here today, in a sense, to talk about how to get help, how to be a good advocate for yourself or for your friend. It can be many things, right? So for example, when someone's brought in under the Mental Health Act by going to the courthouse, I always say to that family member, and when they bring your loved one to the hospital, try to be at the hospital, or at least get a note to the doctor, or write down what your concerns are, because otherwise all they have is what the person is saying,
Yeah.
what the judge might have written down for the police. So part of being an advocate for your loved one or for yourself is going in with what your list of concerns is, whether it's for your own self or for your family member. Making sure the doctor, I have 3 concerns today. Do you have time to address all 3? Right? Don't bring in 20, because they're not going to have time for 20. You know, my doctor says, there's a big sign in his office, please only bring 2 concerns. No, so I've been at the doctor a lot lately, and I'm like, I've got 3. Are we good with 3? Yes, Ryan, we're good with 3. So you need to plan it out and you know, bring information, be a good advocate, and we're going to talk a little bit more about that advocacy.
I think you've answered my question.
Oh, sorry. I
No,
tend
you
to
did,
go on.
you did. It was good.
oh, I was just gonna ask if they are, I mean, if you fill out this form with the courts, is it something that they can just leave? I mean, are they at the hospital up until they're treated? I mean, diagnosed?
Good question. So what happens is the form gets filled out. The judge says, yes, your son needs to be brought to the hospital. The police find your son, they bring him to the hospital. At the hospital, that actually is very helpful. Thank you.
Yeah.
I thought of that earlier too.
Very
So,
observant.
once you're at the hospital, right or wrong in Alberta and Canada to some extent, the doctors still essentially are the big authority makers, decision makers for care and treatment. So once you're at the hospital, having been brought there under the Mental Health Act, the doctor then does a basic assessment. That assessment could be 30 seconds, looking at a person that they feel is out of control in what they call a seclusion room, and they're like, yep, that guy needs to be detained under the Mental Health Act. They write what's called an admission certificate, and that person is then admitted to the hospital for up to 24 hours. And within that 24-hour period, a second certificate may be written if a second doctor feels it's necessary, and that extends the length of time a person be kept in the hospital against their will for up to 1 month. And then there's a whole process for treatment and things like that. Again, this is not something we like to do, this is not something we want to do, but sometimes it's something we have to do, right? So this is for the when we have